Welcome to this chapter on the ADA 2025 guidelines. Today we explore the latest updates from the American Diabetes Association. Remember, you can watch workshops, podcasts, and videos about internal medicine on our platform. Enjoy.
Diabetes Care, Standards of Care in Diabetes, 2025.
Welcome to this chapter of the day with the guides that we're going to talk about the ADA 2025 that you have been asking for a lot. I hope you enjoy it. I take this opportunity to remind you that you can acquire my internal medicine diploma on the platform. Let's start with the main changes.
Table of Contents. Improving care and promoting health in populations. Diagnosis and classification of diabetes. Prevention or delay of diabetes and associated comorbidities. Comprehensive medical evaluation and assessment of comorbidities. Facilitating positive health behaviors and well-being to improve health outcomes. Glycemic goals and hypoglycemia. Diabetes technology. Obesity and weight management for the prevention and treatment of type 2 diabetes. Pharmacologic approaches to glycemic treatment. Cardiovascular disease and risk management. Chronic kidney disease and risk management. Retinopathy, neuropathy, and foot care. Older adults, children, and adolescents. Management of diabetes in pregnancy. Diabetes care in the hospital. Diabetes and advocacy. Evidence. Search of scientific diabetes literature over past year. Recommendations revised per new evidence. Process. Professional Practice Committee. External peer review. Reviewed by the American Diabetes Association's Board of Directors. Living standards. Funding. Funded out of the American Diabetes Association's general revenues. Does not use industry support. Table 1. American Diabetes Association Evidence Grading System 4 Standards of Care in Diabetes. Level of Evidence A. Clear evidence from well-conducted, generalizable randomized controlled trials that are adequately powered, including evidence from a well-conducted multi-center trial, evidence from a meta-analysis that incorporated quality ratings in the analysis, supportive evidence from well-conducted randomized controlled trials that are adequately powered, including evidence from a well-conducted trial at one or more institutions, evidence from a meta-analysis that incorporated quality ratings in the analysis. Level of Evidence B. Supportive evidence from well-conducted cohort studies, including evidence from a well-conducted prospective cohort study or registry, evidence from a well-conducted meta-analysis of cohort studies, supportive evidence from a well-conducted case control study. Level of Evidence C. Supportive evidence from poorly controlled or uncontrolled studies, including evidence from randomized clinical trials with one or more major or three or more minor methodological flaws that could invalidate the results. Evidence from observational studies with high potential for bias, such as case series with comparison with historical controls. Evidence from case series or case reports. Conflicting evidence with the weight of evidence supporting the recommendation. Level of Evidence C. Expert consensus or clinical experience. Section 2. Diagnosis and Classification of Diabetes. Standards of Care in Diabetes, 2025. The American Diabetes Association Standards of Care in Diabetes includes the American Diabetes Association's current clinical practice recommendations and is intended to provide the components of diabetes care, general treatment goals and guidelines, and tools to evaluate quality of care. Members of the American Diabetes Association Professional Practice Committee and Interprofessional Expert Committee are responsible for updating the standards of care annually or more frequently as warranted. For a detailed description of American Diabetes Association standards, statements, and reports, as well as the evidence grading system for American Diabetes Association's clinical practice recommendations and a full list of Professional Practice Committee members, please refer to Introduction and Methodology. Readers who wish to comment on the standards of care are invited to do so at Professional Diabetes Organization Standards of Care. Diabetes mellitus is a group of metabolic disorders of carbohydrate metabolism in which glucose is both underutilized as an energy source and overproduced due to inappropriate gluconeogenesis and glycogenolysis, resulting in hyperglycemia. Diabetes can be diagnosed by demonstrating increased concentrations of glucose in venous plasma or increased glycated hemoglobin in the blood. Diabetes is classified conventionally into several clinical categories: exempli gratia, type 1 or type 2 diabetes, gestational diabetes mellitus, and other specific types derived from other causes, such as monogenic diabetes, exocrine pancreatic disorders, and high-risk medications. Diagnostic tests for diabetes. Diabetes may be diagnosed based on glycated hemoglobin or plasma glucose criteria. Plasma glucose criteria include either the fasting plasma glucose, 2-hour plasma glucose during a 75-gram oral glucose tolerance test, or random glucose accompanied by classic hyperglycemic symptoms, exempli gratia, polyuria, polydipsia, and unexplained weight loss, or hyperglycemic crises, that is, diabetic ketoacidosis and or hyperglycemic hyperosmolar state. Recommendations. 2.1a. Diagnose diabetes based on glycated hemoglobin test or plasma glucose criteria. Plasma glucose criteria include fasting plasma glucose, 2-hour plasma glucose during a 75-gram oral glucose tolerance test, or random plasma glucose accompanied by classic hyperglycemic symptoms or crises. Level of evidence B. 2.1b. In the absence of unequivocal hyperglycemia, such as hyperglycemic crises, diagnosis requires confirmatory testing. Level of evidence B. Screening and diagnosis of diabetes. Fasting plasma glucose, 2-hour plasma glucose during a 75-gram oral glucose tolerance test, and glycated hemoglobin test are appropriate for screening and diagnosis. It should be noted that detection rates of different screening tests vary across populations and individuals. Fasting plasma glucose, 2-hour plasma glucose, and glycated hemoglobin reflect different aspects of glucose metabolism, and the diagnostic cut points for these tests will identify groups with incomplete concordance. Compared with fasting plasma glucose and glycated hemoglobin cut points, the 2-hour plasma glucose value diagnoses more people with prediabetes and diabetes. Furthermore, the efficacy of interventions for primary prevention of type 2 diabetes, meaning the prevention of progression from prediabetes to type 2 diabetes, has been demonstrated mainly among individuals with prediabetes who have impaired glucose tolerance, whether or not they also have elevated fasting glucose. However, these interventions have not shown efficacy for individuals with isolated impaired fasting glucose, nor for those whose prediabetes is defined based on glycated hemoglobin criteria. Table 2.1. Criteria for the diagnosis of diabetes in non-pregnant individuals. Glycated hemoglobin greater than or equal to 6.5%, greater than or equal to 48 millimoles per mole. The test should be conducted in a laboratory using a method that is National Glycohemoglobin Standardization Program certified and standardized to the Diabetes Control and Complications Trial Assay, or fasting plasma glucose greater than or equal to 126 milligrams per deciliter, greater than or equal to 7.0 millimoles per liter. Fasting is defined as no caloric intake for at least 8 hours, or 2-hour plasma glucose greater than or equal to 200 milligrams per deciliter, greater than or equal to 11.1 millimoles per liter during an oral glucose tolerance test. The test should be performed as described by the World Health Organization, using a glucose load containing the equivalent of 75 grams of anhydrous glucose dissolved in water, or in an individual with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose greater than or equal to 200 milligrams per deciliter, greater than or equal to 11.1 millimoles per liter. Random means any time of the day, regardless of the time since the last meal. The same tests may be used to screen for and diagnose diabetes and to detect individuals with prediabetes. Diabetes may be identified anywhere along the spectrum of clinical scenarios: in seemingly low-risk individuals who happen to have glucose testing, in individuals screened based on diabetes risk assessment, and in symptomatic individuals. There is presently insufficient evidence to support the use of continuous glucose monitoring for screening or diagnosis of prediabetes or diabetes. For additional details on the evidence used to establish the criteria for the diagnosis of diabetes or prediabetes, see the American Diabetes Association position statement, diagnosis and classification of diabetes mellitus, and other reports. Table 2.2. Criteria defining prediabetes in non-pregnant individuals. Glycated hemoglobin 5.7 to 6.4%, 39 to 47 millimoles per mole, or fasting plasma glucose between 100 milligrams per deciliter, 5.6 millimoles per liter, and 125 milligrams per deciliter, 6.9 millimoles per liter. This range indicates impaired fasting glucose, or 2-hour plasma glucose between 140 milligrams per deciliter, 7.8 millimoles per liter, and 199 milligrams per deciliter, 11.0 millimoles per liter, during an oral glucose tolerance test. This range indicates impaired glucose tolerance. For all three tests, the risk is continuous, meaning it extends below the lower limit of the range and increases significantly at the higher end. Use of fasting plasma glucose or 2-hour plasma glucose for screening and diagnosis of diabetes. In the less common clinical scenario where a person has classic hyperglycemic symptoms, for example, polyuria, polydipsia, unexplained weight loss, or presents with hyperglycemic crisis, measurement of random plasma glucose is sufficient to diagnose diabetes. Symptoms of hyperglycemia or hyperglycemic crisis plus random plasma glucose greater than or equal to 200 milligrams per deciliter, greater than or equal to 11.1 millimoles per liter. In these cases, knowing the plasma glucose level is critical because, in addition to confirming that symptoms are due to diabetes, it will inform management decisions. Healthcare professionals may also want to know the glycated hemoglobin to determine the chronicity of hyperglycemia. However, in an individual without symptoms, fasting plasma glucose or 2-hour plasma glucose can be used for screening and diagnosis of diabetes. In non-pregnant individuals, fasting plasma glucose or glycated hemoglobin is typically preferred for routine screening due to the ease of administration. However, the 2-hour plasma glucose testing protocol diagnoses more diabetes than the other two tests and is preferentially recommended for screening for some conditions, such as cystic fibrosis-related diabetes or post-transplantation diabetes mellitus. In the absence of classic hyperglycemic symptoms, repeat testing is required to confirm the diagnosis regardless of the test used. See confirming the diagnosis below. Table 2.3. Considerations related to the use and interpretation of laboratory measurements of blood sugar and glycated hemoglobin. Cost. Blood sugar tests are inexpensive and widely available in most laboratories worldwide. Glycated hemoglobin tests are more expensive than blood sugar tests and are not as widely available globally. Time frame of high blood sugar. Blood sugar tests provide an immediate measurement. Glycated hemoglobin tests reflect long-term blood sugar levels over the past 2 to 3 months. Pre-analytical stability. Blood sugar tests have poor stability before processing. The liquid portion of the blood must be separated immediately, or samples must be kept on ice to prevent sugar breakdown. Glycated hemoglobin tests have good stability before processing. Sample type. Blood sugar tests can vary depending on sample type, including liquid blood, clotted blood, or whole blood, and can be taken from small blood vessels, larger veins, or arteries. Glycated hemoglobin tests require a whole blood sample. Test standardization. Blood sugar tests are not standardized, meaning measurements may vary across laboratories. Glycated hemoglobin tests are well standardized, ensuring consistency. Fasting requirements. Blood sugar tests require fasting or timed samples. Glycated hemoglobin tests do not require fasting, and no preparation is needed. Variability within the same individual. Blood sugar tests show high variability in the same person. Glycated hemoglobin tests show low variability in the same person. Short-term factors affecting levels. Blood sugar levels can be influenced by food intake, stress, recent illness, or physical activity. Glycated hemoglobin levels are unaffected by food intake, stress, illness, or physical activity. Other individual factors affecting test results. Blood sugar levels can be affected by daily fluctuations, medications, alcohol, smoking, and bilirubin levels. Glycated hemoglobin levels can be influenced by changes in red blood cell lifespan, including anemia, iron levels, surgical removal of the spleen, blood loss, transfusion, destruction of red blood cells, enzyme deficiencies, human immunodeficiency virus, liver disease, kidney disease, dialysis, or pregnancy. Test interferences. Blood sugar tests can be affected by sample handling, processing time, breakdown of red blood cells, very high fat levels in the blood, or very high bilirubin levels. Glycated hemoglobin tests can be affected by differences in hemoglobin structure, very high fat levels in the blood, or very high bilirubin levels. An advantage of glucose testing is that these assays are inexpensive and widely available. Disadvantages include the high diurnal variation in glucose and fasting requirement. Individuals may have difficulty fasting for the full 8-hour period or may misreport their fasting status. Recent physical activity, illness, or acute stress can affect glucose concentrations. Glycolysis is also an important and under-recognized concern with glucose testing. Glucose concentrations will be falsely low if samples are not handled properly and promptly prior to analysis. People should follow a mixed eating pattern with at least 150 grams of carbohydrates on the 3 days prior to oral glucose tolerance test. Antecedent carbohydrate restriction in the days prior to oral glucose tolerance test can falsely elevate post-challenge glucose levels, potentially resulting in a false positive oral glucose tolerance test. Use of glycated hemoglobin for screening and diagnosis of diabetes. Recommendations. 2.2a. The glycated hemoglobin test should be performed using a method that is certified by the National Glycohemoglobin Standardization Program as traceable to the Diabetes Control and Complications Trial Reference Assay. Level of evidence B. 2.2b. Point-of-care glycated hemoglobin testing for diabetes screening and diagnosis should be restricted to devices approved for diagnosis by the United States Food and Drug Administration at clinical laboratory improvement amendments. Certified laboratories that perform testing of moderate complexity or higher by trained personnel. Level of evidence B. 2.3. Evaluate for the possibility of a problem or interference with either test when there is consistent and substantial discordance between blood glucose values and glycated hemoglobin test results. Level of evidence B. 2.4. In conditions associated with an altered relationship between glycated hemoglobin and glycemia, such as some hemoglobin variants, pregnancy, second and third trimesters, and the postpartum period. Glucose, 6-phosphate dehydrogenase deficiency, human immunodeficiency virus, hemodialysis, recent blood loss or transfusion, hemolysis, or erythropoietin therapy. Plasma glucose criteria should be used to diagnose diabetes. Level of evidence B. The glycated hemoglobin test should be performed using a method that is certified by the National Glycohemoglobin Standardization Program and standardized or traceable to the Diabetes Control and Complications Trial Reference Assay. Outside the United States, some assays are National Glycohemoglobin Standardization Program certified, but many more are International Federation of Clinical Chemistry certified, a similarly stringent process. Point-of-care glycated hemoglobin assays may be National Glycohemoglobin Standardization Program certified and cleared by the United States Food and Drug Administration for use in monitoring glycemic management in people with diabetes in both clinical laboratory improvement amendments, regulated and clinical laboratory improvement amendments waive settings. Food and Drug Administration approved point-of-care glycated hemoglobin testing can be used in laboratories or sites that are clinical laboratory improvement amendments certified, are inspected, and meet the clinical laboratory improvement amendments quality standards. These standards include specified personnel requirements, including documented annual competency assessments, and participation 3 times per year in an approved proficiency testing program. Glycated hemoglobin has several advantages compared with fasting plasma glucose and oral glucose tolerance test, including greater convenience, fasting is not required, greater pre-analytical stability, and fewer day-to-day perturbations during stress, changes in nutrition, or illness. However, it should be noted that there is lower sensitivity of glycated hemoglobin at the designated cut point compared with that of 2-hour plasma glucose, as well as limited access in some parts of the world. The glycated hemoglobin reflects glucose bound to hemoglobin over the lifespan of the erythrocyte, 120 days, and is thus a weighted average that is more heavily affected by recent blood glucose exposure. There is controversy regarding racial differences in glycated hemoglobin. Studies have found that African American individuals have slightly higher glycated hemoglobin levels than non-Hispanic white or Hispanic people. The glucose-independent racial difference in glycated hemoglobin is small, 0.3 percentage points, and may reflect genetic differences in hemoglobin or red cell turnover that vary by ancestry. There is an emerging understanding of the genetic determinants of glycated hemoglobin, but the field lacks adequate genetic data in diverse populations. While some genetic variants might be more common in certain race or ancestry groups, it is important that we do not use race or ancestry as proxies for poorly understood genetic differences. Reassuringly, studies have shown that the association of glycated hemoglobin with risk for complications appears to be similar in African American and non-Hispanic white populations. This means that clinically meaningful changes in glycated hemoglobin can be seen in, for instance, thalassemia or folate deficiency. Glycated hemoglobin may not be a suitable diagnostic test in people with anemia, people treated with erythropoietin, or people undergoing hemodialysis or human immunodeficiency virus treatment. Some hemoglobin variants can interfere with glycated hemoglobin test results, but this depends on the specific assay. For individuals with a hemoglobin variant but normal red blood cell turnover, such as those with the sickle cell trait, and glycated hemoglobin assay without interference from hemoglobin variants should be used. An updated list of glycated hemoglobin assays with interferences is available at ngsp.org/interf.asp. Another genetic variant, X-linked glucose 6-phosphate dehydrogenase G2O2A, carried by 11% of African American individuals in the United States, is associated with a decrease in glycated hemoglobin of about 0.8% in homozygous men and 0.7% in homozygous women compared with levels in individuals without the variant. Confirming the diagnosis. Unless there is a clear clinical diagnosis, such as individual with classic symptoms of hyperglycemia or hyperglycemic crisis and random plasma glucose greater than or equal to 200 milligrams per deciliter, greater than or equal to 11.1 millimoles per liter, confirmation is necessary to establish the diagnosis. This can be accomplished by two abnormal screening test results, measured either at the same time or at two different time points. If using samples at two different time points, it is recommended that the second test, which may be either a repeat of the initial test or a different test, be performed in a timely manner. For example, if the glycated hemoglobin is 7%, 53 millimoles per mole, and a repeat result is 6.8%, 51 millimoles per mole, the diagnosis of diabetes is confirmed. Two different tests, such as glycated hemoglobin and fasting plasma glucose, both having results above the diagnostic threshold when collected at the same time or at two different time points, would also confirm the diagnosis. On the other hand, if an individual has discordant results from two different tests, then the test result that is above the diagnostic cut point should be repeated, with careful consideration of factors that may affect measured glycated hemoglobin or glucose levels. The diagnosis is made based on the confirmatory screening test. For example, if an individual meets the diabetes criterion of glycated hemoglobin, two results greater than or equal to 6.5%, greater than or equal to 48 millimoles per mole, but not fasting plasma glucose, less than 126 milligrams per deciliter, less than 7.0 millimoles per liter. That person should nevertheless be considered to have diabetes. If individuals have test results near the margins of the diagnostic threshold, the healthcare professional should educate the individual about the onset of possible hyperglycemic symptoms and repeat the test in 3 to 6 months. Consistent and substantial discordance between glucose values and glycated hemoglobin test results should prompt additional follow-up to determine the underlying reason for the discrepancy, including evaluation for the possibility of a problem or interference with either test, and whether it has clinical implications for the individual. In addition, consider other biomarkers, such as fructosamine and glycated albumin, which are alternative measures of chronic hyperglycemia that are approved for clinical use for monitoring glycemic management in people with diabetes. Classification. Recommendations. 2.5. Classify people with hyperglycemia into appropriate diagnostic categories to aid in personalized management. Level of evidence. E. Diabetes is classified conventionally into several clinical categories, although these are being reconsidered based on genetic, metabolomic, and other characteristics and pathophysiology. 1. Type 1 diabetes, due to autoimmune beta cell destruction, usually leading to absolute insulin deficiency, including latent autoimmune diabetes in adults. 2. Type 2 diabetes, due to a non-autoimmune progressive loss of adequate beta cell insulin secretion, frequently on the background of insulin resistance. 3. Specific types of diabetes due to other causes, like monogenic diabetes syndromes, diseases of the exocrine pancreas, and drug or chemical-induced diabetes. 4. Gestational diabetes mellitus, diabetes diagnosed in the second or third trimester of pregnancy that was not clearly overt diabetes prior to gestation, or other types of diabetes occurring throughout pregnancy, such as type 1 diabetes. Type 1 diabetes and type 2 diabetes are heterogeneous diseases in which clinical presentation and disease progression may vary considerably. Classification is important for determining personalized therapy, but some individuals cannot be clearly classified as having type 1 or type 2 diabetes at the time of diagnosis. The traditional paradigms of type 2 diabetes having onset only in adults and type 1 diabetes having onset only in children are not accurate, as both diseases occur in all age groups. Children with type 1 diabetes often present with the hallmark symptoms of polyuria, polydipsia, and approximately half present with diabetic ketoacidosis. The onset of type 1 diabetes may be more variable in adults. They may not present with the classic symptoms seen in children and may progress to insulin replacement more slowly. The features most useful in determination of type 1 diabetes include younger age at diagnosis, 360 milligrams per deciliter, greater than 20 milligrams per deciliter at presentation. Other features classically associated with type 1 diabetes, such as ketosis without acidosis, osmotic symptoms, family history, or a history of autoimmune diseases, are weak discriminators. Occasionally, people with type 2 diabetes may present with diabetic ketoacidosis, particularly members of certain racial, ethnic, and ancestral groups. Exempli gratia, African American and Hispanic or Latino adults who may present with ketosis-prone type 2 diabetes. This form of diabetes is strongly inherited and is not human leukocyte antigen associated. An absolute requirement for insulin replacement therapy in affected individuals may be intermittent. It is important for healthcare professionals to realize that classification of diabetes type is not always straightforward at presentation, and that misdiagnosis is common and can occur in 40% of adults with new type 1 diabetes. For example, adults with type 1 diabetes misdiagnosed as having type 2 diabetes. In comparison, individuals with maturity-onset diabetes of the young, MODY, may be misdiagnosed as having type 1 diabetes. Although difficulties in distinguishing diabetes type may occur in all age groups at onset, the diagnosis generally becomes more obvious over time in people with beta cell deficiency as the degree of beta cell deficiency becomes clear. One useful clinical tool for distinguishing diabetes type is the ABBCC approach. Age. Exempli gratia. For individuals less than 35 years old, consider type 1 diabetes. Autoimmunity. For example, personal or family history of autoimmune disease or polyglandular autoimmune syndromes. Body habitus. For instance, body mass index 25 kilograms per square meter. Background, such as family history of type 1 diabetes. Control. Preferred term is goal, that is, the inability to achieve glycemic goals on non-insulin therapies, and comorbidities, such as treatment with immune checkpoint inhibitors for cancer can cause acute autoimmune type 1 diabetes. In both type 1 and type 2 diabetes, Genetic and environmental factors can result in the progressive loss of beta cell mass and/or function that manifests clinically as hyperglycemia. Once hyperglycemia occurs, people with all forms of diabetes are at risk for developing the same chronic complications, although rates of progression may differ. The identification of individualized therapies for diabetes in the future will be informed by better characterization of the many paths to beta cell demise or dysfunction. Across the globe, many groups are working on combining clinical, pathophysiological, and genetic characteristics to more precisely define the subsets of diabetes that are currently clustered into the type 1 diabetes versus type 2 diabetes nomenclature, with the goal of optimizing personalized treatment approaches. A diagnosis of type 1 diabetes does not preclude also having features classically associated with type 2 diabetes. Exempli gratia, insulin resistance, obesity, and other metabolic abnormalities. And until more precise subsets are used in clinical practice, it may be appropriate to categorize such an individual as having features of both type 1 and type 2 diabetes to facilitate access to appropriate treatment. For example, glucagon-like peptide 1 receptor agonist or sodium glucose cotransporter 2 inhibitor therapies for potential weight and other cardiometabolic benefits, and monitoring systems. Characterization of the underlying pathophysiology is more precisely developed in type 1 diabetes than in type 2 diabetes. In at-risk cohorts followed from birth or a very young age, seroconversion rarely occurs before 6 months of age, and there is a peak in seroconversion between 9 and 24 months of age. The rate of progression is dependent on the age at first detection of an autoantibody, number of autoantibodies, autoantibody specificity, and autoantibody titer. Glucose and glycated hemoglobin levels may rise well before the clinical onset of diabetes. For example, changes in fasting plasma glucose and 2 hours plasma glucose can occur about 6 months before diagnosis, making diagnosis feasible under ideal situations of serial monitoring of individuals at high risk of type 1 diabetes before the onset of diabetic ketoacidosis. 3 distinct stages of type 1 diabetes have been defined and serve as a framework for research and regulatory decision-making. There is debate as to whether slowly progressive autoimmune diabetes with an adult onset should be termed latent autoimmune diabetes in adults, LADA, or type 1 diabetes. The clinical priority with detection of latent autoimmune diabetes in adults is awareness that slow autoimmune beta cell destruction can occur in adults, leading to a long duration of marginal insulin secretory capacity. For this classification, all forms of diabetes mediated by autoimmune beta cell destruction independent of age of onset are included under the rubric of type 1 diabetes. Use of the term latent autoimmune diabetes in adults is common and acceptable in clinical practice and has the practical impact of heightening awareness of a population of adults likely to have progressive autoimmune beta cell destruction, thus accelerating insulin initiation prior to deterioration of glucose management or development of diabetic ketoacidosis. At the same time, there is evidence that application of only a single imperfect autoantibody test for determining latent autoimmune diabetes in adults, LADA, classification may lead to misclassification of some individuals with type 2 diabetes. Diagnostic accuracy may be improved by using higher specificity tests, using confirmatory testing for other autoantibodies, and restricting testing to those with clinical features suggestive of autoimmune diabetes. The paths to beta cell demise and dysfunction are less well defined in type 2 diabetes, but deficient beta cell insulin secretion, frequently in the setting of insulin resistance, appears to be the common denominator. Type 2 diabetes is associated with insulin secretory defects related to genetic predisposition, epigenetic changes, inflammation, and metabolic stress. Type 2 diabetes is associated with insulin secretory defects related to genetic predisposition, epigenetic changes, inflammation, and metabolic stress. Future classification schemes for diabetes will likely focus on the pathophysiology of the underlying beta cell dysfunction. This flowchart provides a structured approach for investigating suspected type 1 diabetes in newly diagnosed adults, specifically based on data from white European populations. It serves as a diagnostic guide to differentiate between type 1, type 2, or monogenic diabetes, helping clinicians determine the most appropriate course of action. The initial step in the process is evaluating whether the patient has characteristics suggestive of type 1 diabetes. If so, islet autoantibodies should be tested to confirm an autoimmune origin. A positive result indicates a classification of type 1 diabetes. However, if no autoantibodies are detected, further investigations are required, including assessing whether the patient exhibits features of type 2 diabetes or monogenic diabetes. For individuals older than 35 years, a C-peptide test is recommended to evaluate pancreatic insulin production. If C-peptide levels are below 200 picomoles per liter, the diagnosis is likely type 1 diabetes, confirming significant insulin deficiency. If the levels fall between 200 to 600 picomoles per liter, the classification remains uncertain, and a follow-up test after 5 years is advised to reassess the patient's insulin production. Conversely, a C-peptide level above 600 picomoles per liter suggests type 2 diabetes or monogenic diabetes, warranting further genetic testing when available. For younger individuals, under 35 years old, the presence of characteristics associated with monogenic diabetes is examined. These features may include atypical presentation, a strong family history, or genetic markers linked to specific forms of monogenic diabetes. If such characteristics are identified, genetic testing is recommended for confirmation. If a patient's classification remains unclear, a clinical decision must be made regarding treatment. In cases where insulin therapy is uncertain, a trial of non-insulin therapy may be appropriate, with close monitoring to ensure prompt intervention if glycemic control deteriorates. Ultimately, this flowchart serves as a valuable tool for guiding clinical decisions and optimizing diabetes management based on individual patient characteristics. Flowchart for the investigation of suspected type 1 diabetes in newly diagnosed adults, based on data from white European populations. Adult with suspected type 1 diabetes. Step 1. Test for islet autoantibodies. If islet autoantibodies are positive, classify as type 1 diabetes. If islet autoantibodies are negative, which occurs in 5 to 10% of adult-onset type 1 diabetes, proceed to further evaluation. Step 2. Consider age. If the individual is less than 35 years old, classify as type 1 diabetes. If the individual is older than 35 years, continue evaluation. Step 3. Evaluate for characteristics of monogenic diabetes. If monogenic diabetes characteristics are present, conduct genetic testing for monogenic diabetes where available. If monogenic diabetes characteristics are not present, proceed to further evaluation. Step 4. Consider testing C-peptide levels. If type 2 diabetes characteristics are present, conduct C-peptide testing after more than 3 years of diabetes duration. If type 2 diabetes characteristics are not present, conduct an immediate C-peptide test. Step 5. Classify based on C-peptide levels. If C-peptide levels are less than 200 picomoles per liter, classify as type 1 diabetes. If C-peptide levels are between 200 and 600 picomoles per liter, classification is indeterminate, and consider repeating C-peptide testing after 5 years. If C-peptide levels are greater than 600 picomoles per liter, classify as type 2 diabetes. Step 6. Make a clinical decision for unclear classifications. If classification remains unclear, decide the appropriate treatment based on the patient's clinical profile. A trial of non-insulin therapy may be appropriate. Figure 2.1. Flowchart for investigation of suspected type 1 diabetes in newly diagnosed adults, based on data from white European populations. No single clinical feature confirms type 1 diabetes in isolation. Glutamic acid decarboxylase should be the primary antibody measured and, if negative, should be followed by islet tyrosine phosphatase 2 and/or zinc transporter 8 where these tests are available. In individuals who have not been treated with insulin, antibodies against insulin may also be useful. In those diagnosed at less than 35 years of age who have no clinical features of type 2 diabetes or monogenic diabetes, a negative result does not change the diagnosis of type 1 diabetes, since 5 to 10% of people with type 1 diabetes do not have antibodies. Monogenic diabetes is suggested by the presence of one or more of the following features: glycated hemoglobin less than 58 mol/mol, less than 7.5%. At diagnosis, one parent with diabetes. Features of a specific monogenic cause: exempli gratia, renal cysts, partial lipodystrophy, maternally inherited deafness, and severe insulin resistance in the absence of obesity. And monogenic diabetes prediction model probability greater than 5%. Diabetesgenes.org Exeter Diabetes App Modi Calculator. A C-peptide test is only indicated in people receiving insulin treatment. A random sample with concurrent glucose within 5h of eating can replace a formal C-peptide stimulation test in the context of classification. If the result is greater than or equal to 600 picomoles per liter, greater than or equal to 1.8 nanograms per milliliter, the circumstances of testing do not matter. If the result is less than 600 picomoles per liter, less than 1.8 nanograms per milliliter, and the concurrent glucose is less than 4 millimoles per liter, less than 70 milligrams per deciliter, or the person may have been fasting, consider repeating the test. Results showing very low levels, e.g., less than 80 picomoles per liter, less than 0.24 nanograms per milliliter, do not need to be repeated. Where a person is insulin treated, C-peptide must be measured prior to insulin discontinuation to exclude severe insulin deficiency. Why? Do not test C-peptide within 2 weeks of a hyperglycemic emergency. Features of type 2 diabetes include increased BMI, greater than or equal to 25 kilograms per square meter, absence of weight loss, absence of ketoacidosis, and less marked hyperglycemia. Less discriminatory features include non-white ethnicity, family history, longer duration and milder severity of symptoms prior to presentation, features of metabolic syndrome, and absence of a family history of autoimmunity. If genetic testing does not confirm monogenic diabetes, the classification is unclear and a clinical decision should be made about treatment. Type 2 diabetes should be strongly considered in older individuals. In some cases, investigation for pancreatic or other types of diabetes may be appropriate. A person with possible type 1 diabetes who is not treated with insulin will require careful monitoring and education so that insulin can be rapidly initiated in the event of glycemic deterioration. C-peptide values 200 to 600 picomoles per liter, 0.6 to 1.8 nanograms per milliliter, are usually consistent with type 1 diabetes or maturity-onset diabetes of the young, but may occur in insulin-treated type 2 diabetes, particularly in people with normal or low BMI or after long duration. Reprinted and adapted from Holt and colleagues. Type 1 diabetes. Recommendations. 2.6. Screening for presymptomatic type 1 diabetes may be done by detection of autoantibodies to insulin, glutamic acid decarboxylase, islet antigen 2, or zinc transporter 8. Level of evidence B. 2.7. Autoantibody-based screening for presymptomatic type 1 diabetes should be offered to those with a family history of type 1 diabetes or otherwise known elevated genetic risk. Level of evidence B. 2.8. Having multiple confirmed islet autoantibodies is a risk factor for clinical diabetes. Testing for dysglycemia may be used to further forecast near-term risk. When multiple islet autoantibodies are identified, referral to a specialized center for further evaluation and/or consideration of a clinical trial or approved therapy to potentially delay development of clinical diabetes should be considered. Level of evidence B. 2.9. Standardized islet autoantibody tests are recommended for classification of diabetes in adults who have phenotypic risk factors that overlap with those for type 1 diabetes. Exempli gratia, younger age at diagnosis, unintentional weight loss, ketoacidosis, or short time to insulin treatment. Level of evidence C. Immune-mediated diabetes. Autoimmune type 1 diabetes accounts for 5 to 10% of diabetes and is caused by autoimmune destruction of the pancreatic beta cells. Autoimmune markers include islet cell autoantibodies and autoantibodies to glutamic acid decarboxylase, GAD, such as GAD65, insulin, the tyrosine phosphatases islet antigen 2 and islet antigen 2 beta, and zinc transporter 8. Numerous clinical studies are being conducted to test various methods of preventing or delaying type 1 diabetes in those with evidence of islet autoimmunity. TrialNet.org Our research prevention studies. The disease has strong human leukocyte antigen associations, with linkage to the DQB1 and DRB1 haplotypes, and genetic screening has been used in some research studies to identify high-risk populations. Specific alleles in these genes can be either predisposing, for example, DRB1 *0301, DQB1 *0201, DR3, DQ2, and DRB1 *0401, DQB1 *0302, DR4, DQ8, or protective, such as DRB1 *1501 and DQA1 *0102, DQB1 *0602. Stage 1 of type 1 diabetes is defined by the presence of 2 or more of these autoantibodies and normoglycemia. At stage 1, the 5-year risk of developing symptomatic type 1 diabetes is 44% overall, but varies considerably based on number, titer, and specificity of autoantibodies, as well as age of seroconversion and genetic risk. Stage 2 includes individuals with multiple islet autoantibodies and dysglycemia not yet diagnostic of diabetes. At stage 2 of the disease, there is 60% risk by 2 years and 75% risk within 5 years of developing a clinical diagnosis of type 1 diabetes. A consensus guidance provides expert recommendations on what should be monitored and how often these factors should be monitored in individuals with pre-symptomatic type 1 diabetes. The rate of beta cell destruction is quite variable, being rapid in some individuals, particularly but not exclusively in infants and children, and slow in others, mainly but not exclusively adults. Children and adolescents often present with diabetic ketoacidosis as the first manifestation of the disease, and rates in the United States have increased over the past 20 years. Others have modest fasting hyperglycemia that can rapidly change to severe hyperglycemia and/or diabetic ketoacidosis with infection or other stress. Adults may retain sufficient beta cell function to prevent diabetic ketoacidosis for many years. Such individuals may have remission characterized by decreased insulin needs for months or years, eventually become dependent on insulin for survival, and are at risk for diabetic ketoacidosis. At this later stage of the disease, there is little or no insulin secretion, as manifested by low or undetectable levels of plasma C-peptide. Immune-mediated diabetes is the most common form of diabetes in childhood and adolescence, but it can occur at any age. Autoimmune destruction of beta cells has multiple genetic factors and is also related to environmental factors that are still poorly defined. Although individuals did not classically have obesity when they presented with type 1 diabetes, obesity is increasingly common in the general population. As such, obesity should not preclude testing for type 1 diabetes. People with type 1 diabetes are also prone to other autoimmune disorders, such as Hashimoto thyroiditis, Graves' disease, celiac disease, Addison disease, vitiligo, autoimmune hepatitis, myasthenia gravis, and pernicious anemia. See Section 4, Comprehensive Medical Evaluation and Assessment of Comorbidities. Type 1 diabetes can be associated with monogenic polyglandular autoimmune syndromes, including immune dysregulation, polyendocrinopathy, enteropathy, and X-linked syndrome, which is an early-onset systemic autoimmune genetic disorder caused by mutation of the forkhead box protein 3 gene, and another disorder caused by the autoimmune regulator gene mutation. Introduction of immunotherapy, specifically checkpoint inhibitors, for cancer treatment has led to unexpected adverse events, including immune system activation precipitating autoimmune disease. Fulminant onset of type 1 diabetes can occur with diabetic ketoacidosis and low or undetectable levels of C-peptide as a marker of endogenous beta cell function. Fewer than half of these individuals have autoantibodies that are seen in type 1 diabetes, supporting alternate pathobiology. This immune-related adverse event occurs in just under 1% of checkpoint inhibitor-treated individuals but most commonly occurs with agents that block the programmed cell death protein 1 or programmed cell death ligand 1 pathway alone or in combination with other checkpoint inhibitors. To date, the majority of immune checkpoint inhibitor-related cases of type 1 diabetes occur in people with high-risk human leukocyte antigen susceptibility haplotype for type 1 diabetes. However, people with either a neutral or typically protective human leukocyte antigen haplotype for type 1 diabetes can also develop checkpoint inhibitor-associated type 1 diabetes. To date, risk cannot be predicted by family history or autoantibodies, so all healthcare professionals administering these medications or caring for people who have a history of current or past exposure to these agents should be mindful of this adverse effect and educate and monitor individuals appropriately. A number of viruses have been associated with type 1 diabetes, including enteroviruses such as Coxsackie B. During the coronavirus disease 2019 COVID-19 pandemic, numbers of cases of hyperglycemia, diabetic ketoacidosis, and new diabetes increased, suggesting that severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, is a trigger for or can unmask type 1 diabetes. Possible mechanisms of beta cell damage include virus-triggered beta cell death, immune-mediated loss of pancreatic beta cells, and damage to beta cells because of infection of surrounding exocrine cells. The cytokine storm associated with COVID-19 infection is a highly inflammatory state that could also contribute. To better characterize and understand the pathogenesis of new-onset COVID-19-related diabetes, a global registry, COVIDIOB, has been established. Idiopathic type 1 diabetes. Some forms of type 1 diabetes have no known etiologies. Individuals have permanent insulinopenia and are prone to diabetic ketoacidosis, but have no evidence of beta cell autoimmunity. However, only a minority of people with type 1 diabetes fall into this category. Screening for type 1 diabetes risk. The incidence and prevalence of type 1 diabetes are increasing. People with type 1 diabetes often present with acute symptoms of diabetes and markedly elevated blood glucose levels, and 25 to 50% are diagnosed with life-threatening diabetic ketoacidosis. Family history of type 1 diabetes increases the risk of developing type 1 diabetes compared with the general population, but the majority, 90%, of individuals who develop type 1 diabetes do not have a known relative with the disease. Multiple studies indicate that measuring islet autoantibodies in relatives of those with type 1 diabetes in children from the general population or in children from the general population with high genetic risk can identify many individuals who will develop type 1 diabetes. A study reported the risk of progression to type 1 diabetes from the time of seroconversion to autoantibody positivity in 3 pediatric cohorts from Finland, Germany, and the United States of the 585 children who developed more than 2 autoantibodies. Nearly 70% developed type 1 diabetes within 10 years and 84% within 15 years. These findings are highly significant because while the German group was recruited from offspring of parents with type 1 diabetes, the Finnish and American groups were recruited from the general population. Remarkably, the findings in all 3 groups were the same, suggesting that the same sequence of events led to clinical disease in both sporadic and familial cases of type 1 diabetes. Indeed, the risk of type 1 diabetes increases as the number of relevant autoantibodies detected increases. In the Environmental Determinants of Diabetes in the Young, TEDdy, study, type 1 diabetes developed in 21% of 363 subjects with at least 1 autoantibody at 3 years of age. Such testing, coupled with education about diabetes symptoms and close follow-up, has been shown to enable earlier diagnosis and to prevent diabetic ketoacidosis. In several cohort studies, up to 50% of children with only a single autoantibody revert to being islet autoantibody negative during follow-up. Therefore, it is recommended that the first autoantibody positive test be confirmed with a second test within 3 months, preferably in a laboratory that meets the performance standards set by the islet autoantibody standardization program. Type 1 diabetes genetic risk scores have been used in newborn screening to identify those at risk for future presentation of the disease. In a simulation using one such genetic risk score, the majority of those who would go on to develop type 1 diabetes, greater than 77%, could be identified within just 10% of the general population, identifying a subset who may most benefit from autoantibody testing. As many genetic risk studies have been performed in populations of European ancestry and discriminatory ability may differ in those of different ancestry, more large case control cohorts from non-European populations are still needed. Screening programs are available in Europe, such as FR1DA and GPPAD.org, Australia, Exempli Grazia, Type1Screen.org, and the United States, for example, TrialNet.org, AskHealth.org, and CascadeKids.org. General population-based screening programs may offer broader testing where high-quality, validated assays and resources for appropriate follow-up of results are available, with several countries considering making such testing part of standard care. In 2023, Italy introduced nationwide screening for type 1 diabetes and celiac disease in the general population aged 1 to 17 years. Individuals who test autoantibody positive should be provided with or referred for counseling about the risk of developing diabetes symptoms, and diabetic ketoacidosis prevention, and should be given consideration for referral to a specialized center for further evaluation and/or consideration of a clinical trial or approved therapy to potentially delay development of clinical diabetes. Prediabetes and type 2 diabetes. Recommendations. 2.10. Screening for risk of prediabetes and type 2 diabetes with an assessment of risk factors or validated risk calculator should be done in asymptomatic adults. Level of evidence B. 2.11a. Testing for prediabetes or type 2 diabetes in asymptomatic people should be considered in adults of any age with overweight or obesity who have one or more risk factors. Level of evidence B. 2.11b. For all other people, screening should begin at age 35 years. Level of evidence B. 2.11c. In people without prediabetes or diabetes after screening, repeat screening recommended at a minimum of 3-year intervals is reasonable, sooner with symptoms or change in risk. Exempli Grazia, weight gain. Level of evidence C. 2.12. To screen for prediabetes and type 2 diabetes, fasting plasma glucose, 2 hours plasma glucose during 75 grams oral glucose tolerance test, and glycated hemoglobin are each appropriate. Level of evidence B. 2.13. When using oral glucose tolerance test as a screening tool for prediabetes or diabetes, adequate carbohydrate intake, at least 150 grams per day, should be assured for 3 days prior to testing. Level of evidence E. Prediabetes and type 2 diabetes. 2.14. Risk-based screening for prediabetes or type 2 diabetes should be considered after the onset of puberty or after 10 years of age, whichever occurs earlier, in children and adolescents with overweight, body mass index greater than or equal to 85th percentile, or obesity, body mass index greater than or equal to 95th percentile, and who have one or more risk factors for diabetes. Level of evidence B. 2.15a. Consider screening people for prediabetes or diabetes if they are on certain medications, such as glucocorticoids, statins, thiazide diuretics, some human immunodeficiency virus medications, and second-generation antipsychotic medications, as these agents are known to increase the risk of these conditions. Level of evidence C. 2.15b. In people who are prescribed second-generation antipsychotic medications, screen for prediabetes and diabetes at baseline and repeat 12 to 16 weeks after medication initiation or sooner, if clinically indicated, and annually thereafter. Level of evidence B. 2.16. People with human immunodeficiency virus should be screened for diabetes and prediabetes with a fasting plasma glucose test before starting antiretroviral therapy, at the time of switching antiretroviral therapy, and 3 to 6 months after starting or switching antiretroviral therapy. If initial screening results are normal, fasting plasma glucose should be checked annually. Level of evidence C. Table 2.5. Criteria for screening for diabetes or prediabetes in asymptomatic adults. 1. Testing should be considered in adults with overweight or obesity, body mass index at or above 25, or at or above 23 kilograms per square meter in individuals of Asian ancestry who have one or more of the following risk factors. First-degree relative with diabetes, high-risk race, ethnicity, and ancestry. Exempli gratia, African American, Latino, Native American, Asian American. History of cardiovascular disease. Hypertension, defined as a blood pressure at or above 130/80 millimeters of mercury or on therapy for hypertension. High-density lipoprotein cholesterol level less than 35 milligrams per deciliter, less than 0.9 millimoles per liter, and or triglyceride level greater than 250 milligrams per deciliter, greater than 2.8 millimoles per liter. Individuals with polycystic ovary syndrome. Physical inactivity. Other clinical conditions associated with insulin resistance, such as severe obesity, acanthosis nigricans, metabolic dysfunction, associated steatotic liver disease. 2. People with prediabetes, glycated hemoglobin greater than or equal to 5.7%, greater than or equal to 39 millimoles per mole, impaired glucose tolerance, or impaired fasting glucose, should be tested yearly. 3. People who were diagnosed with gestational diabetes mellitus should have testing at least every 1 to 3 years. 4. For all other people, testing should begin at age 35 years. 5. If results are normal, testing should be repeated at a minimum of 3-year intervals, with consideration of more frequent testing depending on initial results and risk status. 6. Individuals in other high-risk groups, for example, people with human immunodeficiency virus, exposure to high-risk medicines, evidence of periodontal disease, history of pancreatitis, should also be closely monitored. Table 2.6. Risk-based screening for type 2 diabetes or prediabetes in asymptomatic children and adolescents in a clinical setting. Screening should be considered in youth who have overweight, greater than or equal to 85th percentile, or obesity, greater than or equal to 95th percentile, and who have one or more additional risk factors. Maternal history of diabetes or gestational diabetes mellitus during the child's gestation. Family history of type 2 diabetes in first or second-degree relative. High-risk race, ethnicity, and ancestry. Signs of insulin resistance or conditions associated with insulin resistance. Acanthosis nigricans, hypertension, dyslipidemia, polycystic ovary syndrome, large or small for gestational age birth weight. Gestational diabetes mellitus. After the onset of puberty or after 10 years of age, whichever occurs earlier. If tests are normal, repeat testing at a minimum of 3-year intervals, or more frequently if body mass index is increasing or risk factor profile is deteriorating, is recommended. Reports of type 2 diabetes before age 10 years exist, and this can be considered with numerous risk factors. Prediabetes is the term used for individuals whose glucose or glycated hemoglobin levels do not meet the criteria for diabetes, yet have abnormal carbohydrate metabolism that results in elevated glucose levels. Dysglycemia, intermediate between normoglycemia and diabetes. People with prediabetes are defined by the presence of impaired fasting glucose and or impaired glucose tolerance and or glycated hemoglobin 5.7 to 6.4%. 39 to 47 millimoles per mole. As prediabetes is an intermediate state between normoglycemia and diabetes, it is a significant risk factor for progression to diabetes, as well as cardiovascular disease and several other cardiometabolic outcomes. Criteria for screening for diabetes or prediabetes in asymptomatic adults are outlined in Table 2.5. Prediabetes is associated with obesity, especially abdominal or visceral obesity, dyslipidemia with high triglycerides and or low high-density lipoprotein cholesterol, and hypertension. The presence of prediabetes should prompt comprehensive screening for cardiovascular risk factors. Diagnosis of prediabetes. Impaired fasting glucose is defined as fasting plasma glucose levels from 100 to 125 milligrams per deciliter, from 5.6 to 6.9 millimoles per liter, and impaired glucose tolerance as 2 hours plasma glucose levels during 75 grams oral glucose tolerance test from 140 to 199 milligrams per deciliter. from 7.8 to 11.0 millimoles per liter. It should be noted that the World Health Organization and a number of diabetes organizations define the impaired fasting glucose lower limit at 110 milligrams per deciliter, 6.1 millimoles per liter. The American Diabetes Association also initially endorsed this impaired fasting glucose lower limit in 1997. However, in 2003, the American Diabetes Association adopted the new range of 100 to 125 milligrams per deciliter, 5.6 to 6.9 millimoles per liter, to better define impaired fasting glucose so that the population risk of developing diabetes with impaired fasting glucose would be similar to that with impaired glucose tolerance. As with the glucose measures, several prospective studies that used glycated hemoglobin to predict the progression to diabetes demonstrated a strong, continuous curvilinear association between glycated hemoglobin and subsequent diabetes. In a systematic review of 44,203 individuals from 16 cohort studies with a follow-up interval averaging 5.6 years, range 2.8 to 12 years, those with glycated hemoglobin between 5.5% and 6%, between 37 and 42 mole/mole, had a substantially increased risk of diabetes, 5 years incidence from 9% to 25%. Those within glycated hemoglobin range of 6.0 to 6.5%, 42 to 48 millimoles per mole, had a 5-year risk of developing diabetes between 25% and 50% and a relative risk 20 times higher than that with glycated hemoglobin of 5%, 31 millimoles per mole. In a community-based study of African American and non-Hispanic white adults without diabetes, baseline glycated hemoglobin was a stronger predictor of subsequent diabetes and cardiovascular events than fasting glucose. And glycated hemoglobin range of 5.7 to 6.4%, 39 to 47 millimoles per mole, identifies a group of individuals at high risk for diabetes and cardiovascular outcomes. These individuals should be informed of their increased risk for diabetes and cardiovascular disease and counseled about effective strategies to lower their risks. See Section 3, Prevention or Delay of Diabetes and Associated Comorbidities. Similar to glucose measurements, the continuum of risk is continuous and curvilinear. As glycated hemoglobin rises, the diabetes risk rises disproportionately. Aggressive interventions and vigilant follow-up should be pursued for those considered at very high risk, exempli gratia, those with glycated hemoglobin greater than 6%, 42 millimoles per mole, and individuals with both impaired fasting glucose and impaired glucose tolerance. The American Diabetes Association Risk Test is an additional option, that is, an awareness tool for the layperson and the healthcare professional, for assessment to determine the appropriateness of screening for diabetes or prediabetes in asymptomatic adults. For additional background regarding risk factors and screening for prediabetes, see Screening and Testing for Prediabetes and Type 2 Diabetes in Asymptomatic Adults and Screening and Testing for Prediabetes and Type 2 Diabetes in Children and Adolescents, below. For details regarding individuals with prediabetes most likely to benefit from a formal behavioral or lifestyle intervention, see Section 3, Prevention or Delay of Diabetes and Associated Comorbidities. Type 2 diabetes accounts for 90 to 95% of all diabetes. This form encompasses individuals who generally have relative, rather than absolute, insulin deficiency and have insulin resistance, that is, decreased biological responses to insulin. There are various causes of type 2 diabetes. Although the specific etiologies are not known, individuals do not have any of the other known causes of diabetes. Most, but not all, people with type 2 diabetes have overweight or obesity. Excess weight itself causes some degree of insulin resistance. Individuals who do not have obesity or overweight by traditional weight criteria may have an increased percentage of body fat distributed predominantly in the abdominal region, including sites involved in metabolic dysfunction. Associated steatotic liver disease and or ectopic sites, exempli gratia, skeletal muscle. Diabetic ketoacidosis seldom occurs spontaneously in type 2 diabetes. When seen, it usually arises in individuals who are insulinopenic and already treated with insulin, for example, missed or inadequate doses. In people with ketosis-prone type 2 diabetes, in association with the stress of another illness such as infection, like COVID-19 or myocardial infarction, in association with illicit drug use, such as cocaine, in association with certain social determinants of health, or with the use of certain medications such as glucocorticoids, second-generation antipsychotics, or sodium glucose cotransporter 2 inhibitors. Hyperglycemic hyperosmolar state is more typically associated with type 2 diabetes, existing or new diagnosis, and is characterized by severe hyperglycemia, hyperosmolality, and dehydration in the absence of significant ketoacidosis. People with diabetes can also have mixed clinical features of both diabetic ketoacidosis and hyperglycemic hyperosmolar state. Type 2 diabetes frequently goes undiagnosed for many years because hyperglycemia develops gradually and, at earlier stages, is often not severe enough for the individual to notice the classic diabetes symptoms caused by hyperglycemia, such as dehydration or unintentional weight loss. Nevertheless, even undiagnosed people with diabetes are at increased risk of developing macrovascular and microvascular complications. People with type 2 diabetes early in the disease course may have insulin levels that appear normal or elevated, yet the failure to normalize blood glucose reflects a relative defect in glucose-stimulated insulin secretion that is insufficient to compensate for insulin resistance. Insulin resistance may improve with weight reduction, physical activity, and/or pharmacologic treatment of hyperglycemia, but is seldom restored to normal. Recent interventions with intensive nutritional changes and exercise, newer pharmacological agents, for example, glucagon-like peptide, 1 receptor agonists, or surgical weight loss can lead to diabetes remission, see Section 8, Obesity and Weight Management for the Prevention and Treatment of Type 2 Diabetes. The risk of developing type 2 diabetes increases with age, obesity, and lack of physical activity. It occurs more frequently in individuals with prediabetes, prior gestational diabetes mellitus, or polycystic ovary syndrome. It is also more common in people with hypertension or dyslipidemia, and in certain racial, ethnic, and ancestral subgroups. It is often associated with a strong genetic predisposition or family history in first-degree relatives, more so than type 1 diabetes. However, the genetics of type 2 diabetes are poorly understood and under intense investigation in this era of precision medicine. The composition of the gut microbiome may also affect the likelihood of developing type 2 diabetes. In adults without traditional risk factors for type 2 diabetes and/or of younger age, consider islet autoantibody testing, for example, glutamic acid decarboxylase autoantibodies, to exclude the diagnosis of type 1 diabetes. Screening and testing for prediabetes and type 2 diabetes in asymptomatic adult. Screening for prediabetes and type 2 diabetes risk through a targeted assessment of risk factors or with an assessment tool, such as the American Diabetes Association risk test, is recommended to guide healthcare professionals on whether performing a diagnostic test is appropriate. Prediabetes and type 2 diabetes meet criteria for conditions in which early detection via screening is appropriate. Both conditions are common and impose significant clinical and public health burdens. There is often a long pre-symptomatic phase before the diagnosis of type 2 diabetes. Simple tests to detect preclinical disease are readily available. The duration of glycemic burden is a strong predictor of adverse outcomes. There are effective interventions that prevent progression from prediabetes to diabetes. It is important to individualize the risk-to-benefit ratio of formal intervention for people with prediabetes and consider person-centered goals. Risk models have explored the benefit, in general finding higher benefit of intervention in those at highest risk, see Section 3, prevention or delay of diabetes and associated comorbidities, and reduced risk of diabetes complications, see Section 10, cardiovascular disease and risk management, Section 11. Chronic kidney disease and risk management, and Section 12, retinopathy, neuropathy, and foot care. In the National Institutes of Health Diabetes Prevention Program Outcomes Study Report, prevention of progression from prediabetes to diabetes resulted in lower rates of developing retinopathy and nephropathy. Figure 2.2, American Diabetes Association Risk Test. This is a diabetes risk test provided by the American Diabetes Association. It helps individuals determine their risk of developing type 2 diabetes by answering a set of questions and calculating a score based on their responses. Diabetes risk test questions. 1. How old are you? Less than 40 years, 0 points. 40 to 49 years, 1 point. 50 to 59 years, 2 points. 60 years or older, 3 points. 2. Are you a man or a woman? Man, 1 point. Woman, 0 points. 3. If you are a woman, have you ever been diagnosed with gestational diabetes? Yes, 1 point. No, 0 points. 4. Do you have a parent, sibling, or child with diabetes? Yes, 1 point. No, 0 points. 5. Have you ever been diagnosed with high blood pressure? Yes, 1 point. No, 0 points. 6. Are you physically active? Yes, 0 points. No, 1 point. 7. What is your weight category? See chart in the image. Weight categories. The test includes a height and weight chart to determine points based on weight. Left column equals 0 points. Middle column equals 1 point. Right column equals 2 points. Results and next steps. Score of 5 or higher equals increased risk for type 2 diabetes. It is recommended to talk to a doctor for further testing. Ways to lower risk include healthy eating, physical activity, and weight management. Similar impact on diabetes complications was reported with screening, diagnosis, and comprehensive risk factor management in the United Kingdom Clinical Practice Research Datalink database. In that report, progression from prediabetes to diabetes augmented risk of complications. Despite the numerous benefits of screening and early diagnosis for prediabetes or diabetes, unfortunately, many people in the United States and globally either remain undiagnosed or are diagnosed late, when complications have already arisen. Additional considerations regarding testing for type 2 diabetes and prediabetes in asymptomatic individuals are described below. Age is a major risk factor for diabetes. Testing should begin at no later than age 35 years for all people. Screening should be considered in adults of any age with overweight or obesity and one or more risk factors for diabetes. Medications. Certain medications, such as glucocorticoids, statins, thiazide diuretics, some HIV medications, and second-generation antipsychotic medications, should be considered when deciding whether to screen for prediabetes or diabetes, as these medications are known to increase the risks of these conditions. For example, people taking second-generation antipsychotic medications require greater monitoring because of an increase in risk of type 2 diabetes associated with this medication. There is a range of effects on metabolic parameters, exempli gratia, hyperglycemia, dyslipidemia, and weight gain, across second-generation antipsychotic medications. People treated with these agents should be screened for prediabetes or diabetes at baseline, rescreened 12 to 16 weeks after medication initiation, and screened annually thereafter. Repeat testing can occur sooner if clinically warranted. People with HIV are at higher risk for developing prediabetes and diabetes. In addition, some antiretroviral therapies may further increase the risk. Therefore, a screening protocol for prediabetes and type 2 diabetes is recommended, as the glycated hemoglobin test may underestimate glycemia in people with HIV. Plasma glucose criteria are preferred to diagnose prediabetes and diabetes. Diabetes risk is increased with certain protease inhibitors and nucleoside or nucleotide reverse transcriptase inhibitors. New-onset diabetes is estimated to occur in more than 5% of individuals infected with HIV on protease inhibitors, whereas more than 15% may have prediabetes. Nucleotide reverse transcriptase inhibitors also affect fat distribution, both lipohypertrophy and lipoatrophy, which is associated with insulin resistance. For people with HIV and antiretroviral-associated hyperglycemia, it may be appropriate to consider discontinuing the problematic antiretroviral agents if safe and effective alternatives are available. Before making antiretroviral substitutions, Carefully consider the possible effect on HIV virological control and the potential adverse effects of new antiretroviral agents. In some cases, antihyperglycemic agents may still be necessary. Testing interval. The appropriate interval between screening tests is not known. The rationale for the 3-year interval is that with this interval, the number of false positive tests that require confirmatory testing will be reduced, and individuals with false negative tests will be retested before substantial time elapses and complications develop. In especially high-risk individuals, such as those with previous values nearer to the diabetes diagnostic cut point, shorter intervals between screenings may be useful. Community screening. Ideally, screening should be carried out within a healthcare setting, including appropriately resourced pharmacies, because of the need for follow-up and treatment. Community screening outside a healthcare setting is generally not recommended because people with positive tests may not seek or have access to appropriate follow-up testing and care. However, in specific situations where an adequate referral system is established beforehand for positive tests, community screening may be considered. Community screening may also be poorly targeted. That is, it may fail to reach the groups most at risk and inappropriately test those at very low risk, or even those who have already been diagnosed. Screening in dental practices. Because of the bidirectional relationship between periodontal disease and diabetes, the utility of screening in a dental setting and referral to primary care as a means to improve the diagnosis of prediabetes and diabetes has been explored. For example, one study estimated that 30% of individuals greater than or equal to 30 years of age seen in general dental practices, including both people with and without periodontal disease, had newly diagnosed dysglycemia. Further research is needed to demonstrate the feasibility, effectiveness, and cost-effectiveness of screening in this setting. For additional background on oral health in relation to prediabetes and type 2 diabetes, see Section 4, Comprehensive Medical Evaluation and Assessment of Comorbidities. Screening and testing for prediabetes and type 2 diabetes in children and adolescents. The epidemiologic studies that formed the basis for the recommendations to use glycated hemoglobin and plasma glucose criteria to diagnose prediabetes and diabetes included only adult populations. However, American Diabetes Association clinical guidance concluded that glycated hemoglobin, fasting plasma glucose, or 2 hours plasma glucose also could be used to test for prediabetes or type 2 diabetes in children and adolescents. In the last decade, the incidence and prevalence of type 2 diabetes in children and adolescents has increased dramatically, especially in certain high-risk racial, ethnic, and ancestral subgroups. See Table 2.6 for recommendations on risk-based screening for type 2 diabetes or prediabetes in asymptomatic children and adolescents in a clinical setting. See Table 2.1 and Table 2.2 for the criteria for the diagnosis of diabetes and prediabetes, respectively, that apply to children, adolescents, and adults. See Section 14, Children and Adolescents, for additional information on type 2 diabetes in children and adolescents. Pancreatic diabetes or diabetes in the context of disease of the exocrine pancreas. Recommendations. 2.17. Screen people for diabetes within 3 to 6 months following an episode of acute pancreatitis and annually thereafter. Screening for diabetes is recommended annually for people with chronic pancreatitis. Level of evidence. C. Pancreatic diabetes, also termed pancreatogenic diabetes or type 3C diabetes, includes both structural, exempli gratia, destruction or removal of normal pancreatic tissue, and functional loss of glucose-normalizing insulin secretion in the context of exocrine pancreatic dysfunction, and is commonly misdiagnosed as type 2 diabetes. The diverse set of etiologies includes pancreatitis, acute and chronic pancreatic inflammation, and associated fibrosis leading to loss of functional exocrine and endocrine pancreatic function, trauma or pancreatectomy, neoplasia, cystic fibrosis, addressed later in this section, hemochromatosis, fibrocalculous pancreatopathy, rare genetic disorders, and idiopathic forms. As such, pancreatic diabetes is the preferred umbrella term. Acute, even a single bout, and chronic pancreatitis can lead to post-pancreatitis diabetes mellitus. A distinguishing feature is concurrent pancreatic exocrine insufficiency. Consider screening individuals with acute and chronic pancreatitis for exocrine pancreatic insufficiency by measuring fecal elastase. Pathological pancreatic imaging, endoscopic ultrasound, magnetic resonance imaging, and computed tomography, and absence of type 1 diabetes, associated autoimmunity. There is loss of both insulin and glucagon secretion and often higher than expected insulin requirements. Risk for microvascular complications appears to be similar to that of other forms of diabetes. For people with pancreatitis and diabetes, therapy should be advanced if glycated hemoglobin goals are not met. Glucose-lowering therapies potentially associated with increased risk of pancreatitis, that is, incretin-based therapies, should be avoided. Early initiation of insulin therapy should be considered. In the context of pancreatectomy, islet autotransplantation can be considered for selected individuals with medically refractory chronic pancreatitis in specialized centers to preserve endogenous islet function and insulin secretion. In some cases, autotransplant can lead to insulin independence. In others, it may decrease insulin requirements. Cystic fibrosis, related diabetes, recommendations 2.18. Annual screening for cystic fibrosis, related diabetes with an oral glucose tolerance test should begin by age 10 years in all people with cystic fibrosis not previously diagnosed with cystic fibrosis, related diabetes. Level of evidence B. 2.19. Glycated hemoglobin is not recommended as a screening test for cystic fibrosis, related diabetes due to low sensitivity. However, a value of greater than or equal to 6.5%, greater than or equal to 48 millimoles per mole, is consistent with a diagnosis of cystic fibrosis, related diabetes. Level of evidence B. 2.20. Beginning 5 years after the diagnosis of cystic fibrosis, related diabetes, annual monitoring for complications of diabetes is recommended. Level of evidence C. Cystic fibrosis is a multi-system condition arising from recessive mutations in the gene encoding the cystic fibrosis transmembrane conductance regulator protein. Pancreatic exocrine damage, which can begin as early as infancy, ultimately leads to pancreatic exocrine insufficiency. Cystic fibrosis, related diabetes is a common comorbidity in people with cystic fibrosis, occurring in about 20% of adolescents and 40 to 50% of adults. The relevance of cystic fibrosis, related diabetes, is highlighted by its association with increased morbidity, mortality, and patient burden. Diabetes in this population, compared with individuals with type 1 or type 2 diabetes, is associated with worse nutritional status, more severe inflammatory lung disease, and greater mortality. Insulin insufficiency is the primary defect in cystic fibrosis, related diabetes. Genetically determined beta cell function and insulin resistance associated with infection and inflammation may also contribute to the development of cystic fibrosis, related diabetes. Milder abnormalities of glucose tolerance are even more common and occur at earlier ages than cystic fibrosis, related diabetes. Whether individuals with impaired glucose tolerance should be treated with insulin replacement has not currently been determined. Although screening for diabetes before the age of 10 years can identify risk for progression to cystic fibrosis, related diabetes in those with abnormal glucose tolerance, no benefit has been established with respect to weight, height, body mass index, or lung function. Oral glucose tolerance test is the recommended screening test for cystic fibrosis, related diabetes. Not unexpectedly, annual oral glucose tolerance tests are perceived as burdensome, and engagement in current cystic fibrosis, related diabetes screening guidelines is poor. With only 30% of adults with cystic fibrosis having annual oral glucose tolerance tests, glycated hemoglobin is not recommended for screening due to low sensitivity. However, a value of greater than or equal to 6.5%, greater than or equal to 48 mole/mole, is consistent with a diagnosis of cystic fibrosis, related diabetes, and reduces patient screening burden. Regardless of age, weight loss or failure of expected weight gain is a risk for cystic fibrosis, related diabetes, and should prompt screening. The Cystic Fibrosis Foundation Patient Registry evaluated 3,553 people with cystic fibrosis and identified 445, 13%, with cystic fibrosis-related diabetes. Early diagnosis and treatment of cystic fibrosis-related diabetes was associated with preservation of lung function. The European Cystic Fibrosis Society Patient Registry reported an increase in cystic fibrosis-related diabetes with age, 10% increase per decade, genotype, decreased lung function, and female sex. Continuous glucose monitoring or homeostasis model assessment of beta cell function may be more sensitive than oral glucose tolerance test to detect risk for progression to cystic fibrosis-related diabetes. However, evidence linking these results to long-term outcomes is lacking, and these tests are not recommended for screening outside the research setting. There is inadequate evidence presently to alter cystic fibrosis-related diabetes screening based on use of highly effective cystic fibrosis transmembrane conductance regulator modulator therapy, which uses small molecule compounds that directly correct the basic defect of the cystic fibrosis transmembrane conductance regulator channel and restore channel function. Cystic fibrosis-related diabetes mortality has significantly decreased over time, and the gap in mortality between people with cystic fibrosis with and without diabetes has considerably narrowed. There are limited clinical trial data on optimal therapy for cystic fibrosis-related diabetes. People with cystic fibrosis-related diabetes should be treated with insulin to attain individualized glycemic goals. See Section 9, Pharmacologic Approaches to Glycemic Treatment, for further information. Additional resources for the clinical management of cystic fibrosis-related diabetes can be found in the Position Statement, Clinical Care Guidelines for Cystic Fibrosis-Related Diabetes, and in the International Society for Pediatric and Adolescent Diabetes 2022 Clinical Practice Consensus Guidelines. Post-transplantation diabetes mellitus. Recommendations 2.21. After organ transplantation, screening for hyperglycemia should be done. A formal diagnosis of post-transplantation diabetes mellitus is best made once the individual is stable on an immunosuppressive plan and in the absence of an acute infection. Level of evidence B. 2.22. The oral glucose tolerance test is the preferred test to make a diagnosis of post-transplantation diabetes mellitus. Level of evidence B. 2.23. Immunosuppressive plans shown to provide the best outcomes for individuals and graft survival should be used, irrespective of post-transplantation diabetes mellitus risk. Level of evidence C. Several terms are used in the literature to describe the presence of diabetes following organ transplantation. New-onset diabetes after transplantation is one such designation that describes individuals who develop new-onset diabetes following transplant. New-onset diabetes after transplantation excludes people with pre-transplant diabetes that was undiagnosed, as well as post-transplant hyperglycemia that resolves by the time of discharge. Another term, post-transplantation diabetes mellitus, describes the presence of diabetes in the post-transplant setting irrespective of the timing of diabetes onset. The clinical importance of post-transplantation diabetes mellitus lies in its impact as a significant risk factor for cardiovascular disease and chronic kidney disease and solid organ transplantation. Hyperglycemia is very common during the early post-transplant period, with 90% of kidney allograft recipients exhibiting hyperglycemia in the first few weeks following transplant. In most cases, such stress or steroid-induced hyperglycemia resolves by the time of discharge. Although the use of immunosuppressive therapies is a major contributor to the development of post-transplantation diabetes mellitus, the risks of transplant rejection outweigh the risks of post-transplantation diabetes mellitus. And the role of the diabetes healthcare professional is to treat hyperglycemia appropriately regardless of the type of immunosuppression. Risk factors for post-transplantation diabetes mellitus include both general diabetes risks, such as age, family history of diabetes, and obesity, and transplant-specific factors, such as use of immunosuppressant agents. Whereas post-transplantation hyperglycemia is an important risk factor for subsequent post-transplantation diabetes mellitus. A formal diagnosis of post-transplantation diabetes mellitus is optimally made once the individual is stable on maintenance immunosuppression, usually at least 45 days, and in the absence of acute infection. The oral glucose tolerance test is recommended for the diagnosis of post-transplantation diabetes mellitus, 1 year post-transplant. However, screening people with fasting plasma glucose and/or glycated hemoglobin can identify high-risk individuals who require further assessment and may reduce the number of overall oral glucose tolerance tests required. Few randomized controlled studies have reported on the short and long-term use of antihyperglycemic agents in the setting of post-transplantation diabetes mellitus. Most studies have reported that transplant individuals with hyperglycemia and post-transplantation diabetes mellitus after transplantation have higher rates of rejection, infection, and rehospitalization. Insulin therapy is the agent of choice for the management of hyperglycemia and diabetes in the hospital setting and can be continued post-discharge. Non-insulin glucose-lowering therapies can also be used for long-term management. The choice of agent is usually made based on the side effect profile of the medication, possible interactions with the individual's immunosuppression plan, and potential cardiovascular and renal benefits in individuals with post-transplantation diabetes mellitus. See Section 9, Pharmacologic Approaches to Glycemic Treatment, for further information. Monogenic diabetes syndromes. Recommendations. 2.24a. Regardless of current age, all people diagnosed with diabetes in the first 6 months of life should have genetic testing for neonatal diabetes. Level of evidence B. 2.24b. Children and young adults who do not have typical characteristics of type 1 or type 2 diabetes and family history of diabetes in successive generations, suggestive of an autosomal dominant pattern of inheritance, should have genetic testing for maturity onset diabetes of the young, MODY. Level of evidence B. 2.24c. In both instances, consultation with a center specializing in diabetes genetics is recommended to understand the significance of genetic mutations and how best to approach further evaluation, treatment, and genetic counseling. Level of evidence C. Monogenic defects that cause beta cell dysfunction, for example, neonatal diabetes and MODY, or insulin resistance syndromes, like monogenic lipodystrophies, are present in a small fraction of people with diabetes, less than 5. Table 2.7 describes the most common causes of monogenic diabetes. For a comprehensive list of causes, see Genetic Diagnosis of Endocrine Disorders and International Society for Pediatric and Adolescent Diabetes 2022 Clinical Practice Consensus Guidelines. Diagnosis of monogenic diabetes. The diagnosis of monogenic diabetes should be considered in children and adults diagnosed with diabetes in early adulthood with the following findings. Diabetes diagnosed within the first 6 months of life. Diabetes without typical features of type 1 or type 2 diabetes. Negative diabetes-associated autoantibodies. No obesity, and lacking other metabolic features, especially strong family history of diabetes. Stable, mild fasting hyperglycemia, 100 to 150 milligrams per deciliter, 5.6 to 8.5 millimoles per liter. Stable glycated hemoglobin between 5.6% and 7.6%, between 38 and 60 millimoles per mole, especially if no obesity. Neonatal diabetes. Diabetes occurring under 6 months of age is termed neonatal diabetes, and about 80 to 85% of cases can be found to have an underlying monogenic cause. Neonatal diabetes occurs much less often after 6 months of age, whereas autoimmune type 1 diabetes rarely occurs before 6 months of age. Neonatal diabetes can either be transient or permanent. Transient diabetes is most often due to overexpression of genes on chromosome 6q24, is recurrent in about half of cases, and may be treatable with medications other than insulin. Permanent neonatal diabetes is most commonly due to autosomal dominant mutations in the genes encoding the KIR6.2 subunit, KCNJ11, and SUR1 subunit, ABCC8, of the beta cell ADP-sensitive potassium channel. Table 2.7. Most common causes of monogenic diabetes. Type: maturity onset diabetes of the young MODY. Gene: HNF1A. Inheritance: passed down from one parent. Clinical features: progressive decline in insulin production, appearing in teenage years or early adulthood. Lower kidney threshold for glucose excretion in urine. Large increase in blood sugar levels 2 hours after consuming glucose. Low levels of a specific inflammatory marker in the blood. Responds well to a type of medication that stimulates insulin release. Gene: HNF4A. Inheritance: passed down from one parent. Clinical features: progressive decline in insulin production, appearing in teenage years or early adulthood. May present with high birth weight and temporary low blood sugar in newborns. Responds well to a type of medication that stimulates insulin release. Gene: HNF1B. Inheritance: passed down from one parent. Clinical features: developmental kidney disease, usually involving cysts. Abnormalities in the urinary and reproductive organs. Underdevelopment of the pancreas. Increased levels of uric acid in the blood. Risk of developing gout. Gene: GCK. Inheritance: passed down from one parent. Clinical features: higher glucose threshold for stimulating insulin release, leading to stable but mildly elevated fasting blood sugar. Usually does not require treatment. Low risk for complications related to high blood sugar. Small increase in blood sugar levels 2 hours after consuming glucose. Type: neonatal diabetes. Gene: KCNJ11. Inheritance: passed down from one parent. Clinical features: can be permanent or temporary. Growth restriction in the womb. Possible delays in development and seizures. Responds well to a type of medication that stimulates insulin release. Gene: INS. Inheritance: passed down from one parent. Clinical features: permanent condition. Growth restriction in the womb. Requires insulin treatment. Gene: ABCC8. Inheritance: passed down from one parent. Clinical features: can be permanent or temporary. Growth restriction in the womb. Rare developmental delay. Responds well to a type of medication that stimulates insulin release. Gene: 6q24, Plagal1, HYMAI. Inheritance: passed down from one parent if duplication occurs. Clinical features: temporary condition. Growth restriction in the womb. Large birth size. Umbilical hernia. Can result from genetic mechanisms like an imbalance in chromosome inheritance or changes in gene regulation. May be treatable with medications other than insulin. Gene: GATA6. Inheritance: passed down from one parent. Clinical features: permanent condition. Underdeveloped pancreas. Heart abnormalities. Insufficient production of digestive enzymes. Requires insulin treatment. Gene: EF2AK3. Inheritance: passed down from both parents. Clinical features: permanent condition. Associated with a syndrome that affects bone growth, digestive enzyme production, and requires insulin treatment. Gene: EF2B1. Inheritance: passed down from one parent. Clinical features: permanent diabetes. May be linked to fluctuating liver function. Gene: FOXP3. Inheritance: passed down through the X chromosome. Clinical features: permanent condition. Linked to an immune system disorder that causes diabetes, thyroid disease, and severe skin inflammation. Requires insulin treatment. The ADA European Association for the Study of Diabetes Type 1 Diabetes Consensus Report recommends that regardless of current age, individuals diagnosed under 6 months of age should have genetic testing. Correct diagnosis has critical implications because 30 to 50% of people with ADP-sensitive potassium-related neonatal diabetes will exhibit improved blood glucose levels when treated with high-dose oral sulfonylureas instead of insulin. Insulin gene mutations are the second most common cause of permanent neonatal diabetes, with insulin therapy being the preferred treatment strategy. Monogenic diabetes has been reported. Individuals in whom monogenic diabetes is suspected should undergo genetic testing. Genetic screening, such as next-generation sequencing, is increasingly available and cost-effective. Consultation with a center specializing in diabetes genetics is recommended to understand the significance of genetic mutations and determine the best approaches for further evaluation, treatment, and genetic counseling. Genetic counseling is essential to ensure that affected individuals comprehend inheritance patterns, recognize the importance of a correct diagnosis, and address comprehensive cardiovascular risk. A diagnosis of one of the three most common forms of MODY, HNF1A MODY, GCK MODY, and HNF4A MODY, enables more cost-effective, personalized therapy. For example, no therapy is required for GCK MODY, and sulfonylureas can be used as first-line therapy for HNF1A MODY and HNF4A MODY. Refer to Section 9, Pharmacologic Approaches to Glycemic Management, for further details. Treatment. For further information. Additionally, diagnosis can lead to identification of other affected family members and can indicate potential extrapancreatic complications in affected individuals. Maturity-onset diabetes of the young. MODY is frequently characterized by onset of hyperglycemia at an early age, classically before age 25 years, although diagnosis may occur at older ages. MODY is characterized by impaired insulin secretion with minimal or no defects in insulin action in the absence of coexistent obesity. It is inherited in an autosomal dominant pattern with abnormalities in at least 14 genes on different chromosomes identified to date. The most commonly reported forms are GCK MODY, MODY2, HNF1A MODY, MODY3, and HNF4A MODY, MODY1. Correct diagnosis of monogenic forms of diabetes is critical because people who have them may be incorrectly diagnosed with type 1 or type 2 diabetes, leading to suboptimal, even potentially harmful, treatment plans and delays in diagnosing other family members. A diagnosis of MODY should be considered in individuals who have atypical diabetes and multiple family members with diabetes, not characteristic of type 1 or type 2 diabetes. Gestational diabetes mellitus. Recommendations. 2.25. In individuals who are planning pregnancy, screen those with risk factors, level of evidence B, and consider testing all individuals of childbearing potential for undiagnosed prediabetes or diabetes. Level of evidence C. 2.26a. Before 15 weeks of gestation, test individuals with risk factors, level of evidence B, and consider testing all individuals, level of evidence E, for undiagnosed diabetes at the first prenatal visit using standard diagnostic criteria, if not screened preconception. 2.26b. Before 15 weeks of gestation, screen for abnormal glucose metabolism to identify individuals who are at higher risk of adverse pregnancy and neonatal outcomes, are more likely to need insulin, and are at high risk of a later gestational diabetes mellitus diagnosis. Level of evidence B. 2.26c. Screen for early abnormal glucose metabolism with dysglycemia using fasting plasma glucose 110 to 125 milligrams per deciliter, 6.1 to 6.9 millimoles per liter, or glycated hemoglobin 5.9 to 6.4%, 41 to 47 millimoles per mole. Level of evidence B. 2.27. Screen for gestational diabetes mellitus at 24 to 28 weeks of gestation in pregnant individuals not previously found to have diabetes or high-risk abnormal glucose metabolism detected earlier in the current pregnancy. Level of evidence A. 2.28. Screen individuals with gestational diabetes mellitus for prediabetes or diabetes at 4 to 12 weeks postpartum, using the 75 grams oral glucose tolerance test and clinically appropriate non-pregnancy diagnostic criteria. Level of evidence B. 2.29. Individuals with a history of gestational diabetes mellitus should have lifelong screening for the development of prediabetes or diabetes every 1 to 3 years. Level of evidence B. Definition. For many years, gestational diabetes mellitus was defined as any degree of glucose intolerance that was first recognized during pregnancy, regardless of the degree of hyperglycemia. The facilitated definition enabled a uniform strategy for the detection and classification of gestational diabetes mellitus. But this definition has limitations. First, evidence indicates that many cases of gestational diabetes mellitus represent pre-existing hyperglycemia detected by routine screening in pregnancy. As such, screening is not widely performed in non-pregnant individuals of reproductive age. The ongoing epidemic of obesity and diabetes has led to increased instances of type 2 diabetes among people of reproductive age, resulting in a rise in undiagnosed type 2 diabetes in early pregnancy. Ideally, undiagnosed diabetes should be identified preconception in individuals with risk factors or high-risk populations, as these groups benefit significantly from preconception care. Such care reduces glycated hemoglobin levels and minimizes risks associated with birth defects, preterm delivery, perinatal mortality, small for gestational age weight, and neonatal intensive care unit admission. Universal early screening for undiagnosed diabetes at less than 15 weeks of gestation may be considered over-selective screening, particularly for populations with high prevalence of risk factors and undiagnosed diabetes among individuals of childbearing age. Strong racial and ethnic disparities exist in the prevalence of undiagnosed diabetes. Thus, early screening serves as a vital step to identify and begin addressing these disparities. Diagnostic criteria for undiagnosed diabetes in early pregnancy mirror those used in non-pregnant individuals. Those identified with diabetes should be classified as having diabetes complicating pregnancy, typically type 2 diabetes, less commonly type 1 diabetes or monogenic diabetes, and managed accordingly. Early abnormal glucose metabolism, defined as fasting glucose thresholds of 110 milligrams per deciliter, 6.1 millimoles per liter, or in glycated hemoglobin of 5.9%, 41 millimoles per mole, may identify individuals at higher risk of adverse pregnancy and neonatal outcomes. Exempli gratia, preeclampsia, macrosomia, shoulder dystocia, and perinatal death, as well as increased likelihood of requiring insulin treatment. Notably, in glycated hemoglobin threshold of 5.7%, 39 millimoles per liter, lacks association with adverse perinatal outcomes. For those with negative early screenings for undiagnosed diabetes or early abnormal glucose metabolism, rescreening for gestational diabetes mellitus between 24 and 28 weeks of gestation is recommended. Screening and diagnostic criteria for gestational diabetes mellitus using the 75 grams oral glucose tolerance test, International Association of Diabetes and Pregnancy Study Groups, and the two-step approach should not be applied during early pregnancy as they are derived from second-half gestational data. Randomized trials of early glucose metabolism treatment have shown modest improvements in neonatal outcomes, 24.9% early treatment versus 30.5% control treatment, but benefits remain uncertain. Suggested management includes nutritional counseling, weekly glucose monitoring, and intensified treatment if fasting plasma glucose exceeds 110 milligrams per deciliter, greater than 6.1 millimoles per liter, before 18 weeks of gestation. Both the fasting plasma glucose and glycated hemoglobin are low-cost tests. An advantage of the glycated hemoglobin test is its convenience, as it can be added to the prenatal laboratories and does not require an early morning fasting appointment. Disadvantages include inaccuracies in the presence of increased red blood cell turnover and hemoglobinopathies, usually reads lower, and higher values with anemia and reduced red blood cell turnover. Glycated hemoglobin is not reliable for screening for gestational diabetes mellitus or for pre-existing diabetes at 15 weeks of gestation or later, in part from the higher red blood cell turnover in pregnancy, but also from the unknown diabetes status prior to pregnancy, which could help distinguish new-onset diabetes from pre-existing diabetes. Gestational diabetes mellitus is often indicative of underlying beta cell dysfunction, which confers a markedly increased risk for later development of glucose intolerance and diabetes in the mother after delivery. As effective prevention interventions are available, individuals diagnosed with gestational diabetes mellitus should receive lifelong screening for prediabetes to allow interventions to reduce diabetes risk, and for type 2 diabetes to allow treatment at the earliest possible time. Diagnosis: gestational diabetes mellitus carries risks for the mother, fetus, and neonate. The Hyperglycemia and Adverse Pregnancy Outcome Study, a large-scale multinational cohort study completed by more than 23,000 pregnant individuals, demonstrated that risk of adverse maternal, fetal, and neonatal outcomes continuously increased as a function of maternal glycemia at 24 to 28 weeks of gestation, even within ranges previously considered normal for pregnancy. For most complications, there was no threshold for risk. These results have led to careful reconsideration of the diagnostic criteria for gestational diabetes mellitus. Gestational diabetes mellitus diagnosis can be accomplished with either of two strategies. The one-step 75 grams oral glucose tolerance test derived from the International Association of Diabetes and Pregnancy Study Group criteria, or the older two-step approach with a 50 grams, non-fasting, screen followed by a 100 grams oral glucose tolerance test for those who screen positive based on the work of Carpenter. Kustin's interpretation of the older O'Sullivan and Mahan criteria. Different diagnostic criteria will identify different degrees of maternal hyperglycemia and maternal or fetal risk, leading experts to debate optimal strategies for the diagnosis of gestational diabetes mellitus. One-step strategy. The International Association of Diabetes and Pregnancy Study Groups examined data from the Hyperglycemia and Adverse Pregnancy Outcome Study and defined diagnostic cut points for gestational diabetes mellitus as the average fasting, 1 hour, and 2 hours plasma glucose values during a 75 grams oral glucose tolerance test in individuals at 24 to 28 weeks of gestation, wherein the cut points were those at which odds for adverse outcomes reached 1.75 times the estimated odds. This one-step strategy was anticipated to significantly increase the incidence of gestational diabetes mellitus from 5 to 6% to 15 to 20%, primarily because only one abnormal value, not two, became sufficient to make the diagnosis. Many regional studies have seen a roughly 1 to 3-fold increase in gestational diabetes mellitus cases using the International Association of Diabetes and Pregnancy Study Groups criteria. A study of pregnancy oral glucose tolerance tests with glucose levels blinded to caregivers found that 11 years after their pregnancies, individuals who would have been diagnosed with gestational diabetes mellitus by the one-step approach, as compared with those without gestational diabetes mellitus, were at 3.4-fold higher risk of developing prediabetes and type 2 diabetes and had children with a higher risk of obesity and increased body fat, suggesting that the group identified as having gestational diabetes mellitus by the one-step approach would benefit from the increased screening for diabetes and prediabetes after pregnancy. The American Diabetes Association recommends the International Association of Diabetes and Pregnancy Study Groups diagnostic criteria to optimize gestational outcomes, because these criteria are the only ones based on pregnancy outcomes rather than endpoints such as prediction of subsequent maternal diabetes. Expected benefits of using International Association of Diabetes and Pregnancy Study Groups criteria for offspring are inferred from intervention trials focusing on individuals with lower levels of hyperglycemia than those identified using older gestational diabetes mellitus diagnostic criteria. Those trials found modest benefits, including reduced rates of large for gestational age births and preeclampsia. Of note, 80 to 90% of participants being treated for mild gestational diabetes mellitus in these two randomized controlled trials could be managed with lifestyle therapy alone. The oral glucose tolerance test glucose cutoffs in these two trials overlapped the thresholds recommended by the International Association of Diabetes and Pregnancy Study Groups, and in one trial, the 2 hours plasma glucose threshold, 140 milligrams per deciliter, 7.8 millimoles per liter, was lower than the cutoff recommended by the International Association of Diabetes and Pregnancy Study Groups, 153 milligrams per deciliter, 8.5 millimoles per liter. No randomized controlled trials of treat-ing versus not treating gestational diabetes mellitus diagnosed by different criteria have been published to date. However, a randomized trial of testing for gestational diabetes mellitus at 24 to 28 weeks of gestation by the one-step method using International Association of Diabetes and Pregnancy Study Groups criteria versus the two-step method by Carpenter-Kustin criteria identified twice as many individuals with gestational diabetes mellitus using the one-step method. Despite treating more individuals for gestational diabetes mellitus using the one-step method, there was no difference in pregnancy and perinatal complications, though concerns were raised about sample size estimates and unanticipated suboptimal engagement with the screen-ing and treatment protocol. For example, In the two-step group, 165 participants not counted as having gestational diabetes mellitus were treated for isolated elevated fasting plasma glucose greater than 95 milligrams per deciliter, greater than 5.3 millimoles per liter. The one-step method identifies long-term risks of maternal prediabetes and diabetes, as well as offspring glucose intolerance and adiposity. Post-hoc gestational diabetes mellitus in individuals diagnosed with this method in the hyperglycemia and adverse pregnancy outcome cohort was associated with higher prevalence of impaired glucose tolerance, higher 30 minutes, 1 hour, and 2 hours glucose levels during the oral glucose tolerance test, and reduced insulin sensitivity and oral disposition index in their offspring at 10 to 14 years of age compared with offspring of mothers without gestational diabetes mellitus. Associations of mothers fasting, 1 hour, and 2 hours values on the 75 grams oral glucose tolerance test were continuous with a comprehensive panel of offspring metabolic outcomes. Hyperglycemia and adverse pregnancy outcome follow-up study data demonstrate that neonatal adiposity and fetal hyperinsulinemia, cord C-peptide, both higher across the continuum of maternal hyperglycemia, are mediators of childhood body fat. Data are lacking on how the treatment of mother's hyperglycemia in pregnancy affects her offspring's risk for obesity, diabetes, and other metabolic disorders. Additional well-designed clinical studies are needed to determine the optimal intensity of monitoring and treatment of individuals with gestational diabetes mellitus diagnosed by the one-step strategy. Two-step strategy. In 2013, the National Institutes of Health convened a consensus development conference to consider diagnostic criteria for diagnosing gestational diabetes mellitus. The 15-member panel had representatives from obstetrics and gynecology, maternal-fetal medicine, pediatrics, diabetes research, biostatistics, and other related fields. The panel recommended continuing a two-step approach to screening that used a 1 hour 50 grams glucose loading test followed by a 3 hours 100 grams oral glucose tolerance test for those who screened positive. The American College of Obstetricians and Gynecologists recommends any of the commonly used thresholds of 130, 135, or 140 milligrams per deciliter for the 1 hour 50 grams glucose loading test. A 2021 United States Preventive Services Task Force systematic review concluded that one-step versus two-step screening is associated with increased likelihood of gestational diabetes mellitus, 11.5% versus 4.9%, but without improved health outcomes. The use of glycated hemoglobin at 24 to 28 weeks of gestation as a screening test for gestational diabetes mellitus does not function as well as the glucose loading test. Importantly, the National Institutes of Health panel noted the lack of clinical trial data demonstrating the benefits of the one-step strategy and the potential negative consequences of identifying a large group of individuals with gestational diabetes mellitus, including medicalization of pregnancy with increased healthcare utilization and costs. Moreover, screening with a 50 grams glucose loading test does not require fasting and therefore is easier to accomplish for many individuals. Treatment of higher threshold maternal hyperglycemia, as identified by the two-step approach, reduces rates of neonatal macrosomia, large for gestational age births, and shoulder dystocia without increasing small for gestational age births. American College of Obstetricians and Gynecologists currently supports the two-step approach, but notes that one elevated value, as opposed to two, may be used for the diagnosis of gestational diabetes mellitus. If this approach is implemented, the incidence of gestational diabetes mellitus will likely increase markedly. American College of Obstetricians and Gynecologists recommends either of two sets of diagnostic thresholds for the 3 hours 100 grams oral glucose tolerance test Carpenter-Custon or National Diabetes Data Group. Each is based on different mathematical conversions of the original recommended thresholds by O'Sullivan and Mahan, which used whole blood and non-enzymatic methods for glucose determination. A secondary analysis of data from a randomized clinical trial of identification and treatment of mild gestational diabetes mellitus demonstrated that treatment was similarly beneficial in people meeting only the lower thresholds per Carpenter-Custon and in those meeting only the higher thresholds per national diabetes data group. If the two-step approach is used, it would appear advantageous to use the Carpenter-Custon lower diagnostic thresholds, as shown in Step 2 in Table 2.8. Future considerations. Data exist to support each strategy, as demonstrated by conflicting recommendations by expert groups. A systematic review of economic evaluations of gestational diabetes mellitus screening found that the one-step method identified more cases of gestational diabetes mellitus and was more likely to be cost-effective than the two-step method. The decision of which strategy to implement must therefore be made based on the relative values placed on factors that have yet to be measured, such as willingness to change practice based on correlation studies rather than intervention trial results, available infrastructure, and importance of cost considerations. The International Association of Diabetes and Pregnancy Study Group's criteria, one-step strategy, have been adopted internationally as the preferred approach. Data that compare population-wide outcomes with one-step versus two-step approaches have been inconsistent to date. Pregnancies complicated by gestational diabetes mellitus per the International Association of Diabetes and Pregnancy Study Group's criteria, but not recognized as such, have outcomes comparable to pregnancies with diagnosed gestational diabetes mellitus by the more stringent two-step criteria. There remains strong consensus that establishing a uniform approach to diagnosing gestational diabetes mellitus will benefit people with gestational diabetes mellitus, caregivers, and policymakers. Longer-term outcome studies are currently underway. References. In today's session, we have delved into the 2025 guidelines released by the American Diabetes Association. These updates are crucial for providing the best possible care for diabetes patients. Stay informed with the latest research and guidelines to ensure optimal care and outcomes. Feel free to explore the workshops, podcasts, and videos about internal medicine available on our platform for more in-depth insights. Thank you for your attention, and I hope you found this information valuable.